Dinesh Koka, founder and CEO behind Onward Assist, a visionary leader transforming cancer diagnostics with the power of AI. With over 22 years of experience in the healthcare industry, he has worked with leading institutions and cancer centers, driving innovation in telepathology, pathology data management, slide viewing and AI capabilities. In passion for clinical diagnostics are more accessible and accurate in helping oncologists making informed treatments for Indian population. He holds an MBA from IIM Lucknow and an engineering degree from University of Madras.
Hi, morning everyone. Sure, so I think I'm set up for about 35-40 minutes, but I think I'll use maybe half of that to talk through what I have, but then it'll be nice to open for questions as well, right, towards the end. The presentation is primarily from my experiences of implementing AI in a clinical setting. I know we were just discussing, so while it is pretty much the buzzword and there's a lot of interest in in understanding what are the types of clinical outcomes that AI can enable, right? There are still a lot of unknowns, right? Hospitals are still pretty much in the early stage, you can say, fairly nascent in terms of understanding what are those solutions out there and which of them can actually work and what is the best way to adopt, right? There's a big gap between all those three, right? Rather than just adopt because that's what everybody is talking about. So first I'll introduce what we do at Onward, at my organization, and then quickly we'll go into what type of solutions are there. And I actually want to spend a bulk of the time around, what determines a successful AI, right? How to drive better adoption or better success of an AI adoption in a clinical setting, right? And that's primarily what my goal has been for the presentation today, right? Without further ado, my organization is called Onward Assist. We primarily work in the cancer analytics space, right? So again, we're talking about while the topic is AI and clinical excellence, there are more fundamental problems in a country like India. We don't have enough pathologists, right? While we add about 15 lakh patients every year, new cancer cases every year, right? So that leads to a problem of, big delta in terms of, delayed reporting, suboptimal quality of biopsy reports, and more importantly, eventually the outcomes, right? Treatment outcomes. And that's primarily what we do. So we work in that space. What you're seeing here is just an example. We build AI algorithms which are trained to essentially, one is mimic a pathologist, right? A pathologist takes about 15 to 20 minutes to report on a biopsy. But if you have, in a country, we have 15 million, right? Or 1.5 crore biopsy slides need to be reported every year, right? So we primarily roll out algorithms which can help the pathologist do their job faster and with higher accuracy. Right? The average accuracy of a biopsy report is about 75%. The doctor plus AI accuracy that we've been able to demonstrate is about 96%. Right? So from a jump of from 75 to 96. And this is across the board, different types of cancers, your primary biopsy, which is your H&E stain, as well as the IHC. Right? So this is just a quick example. If you're able to see, right? So this is what the pathologist needs to do. Right? He or she need to look at the different areas of the slide and actually count, right? If you see those brown colored stains, right? And within a certain amount of time and get it accurate, right? Instead, what we've been able to do is give them the algorithm, right? Where they can choose the different regions of interest or hotspots as they are called. And quickly it gives the count, right? This of course is the example here is a Ki-67, right? It's a proliferation index used across multiple types of, cancers. And then, you saw the problem. That's the reason why the average accuracy is only 75%. And it takes a fair amount of time, right? So the opportunities, can we combine AI with the human and deliver higher, right? And in a country like India, obviously there's a bigger opportunity, right? There's an opportunity for improving access. So we run social, projects as well, right? Public healthcare projects in collaboration with, the state of Andhra. We've done it with PGI. So there is always, while AI is sophistication, right, it's fairly cool. It's always our, the goal for any of us, if you are going to be working on AI-based projects, is also to how can you, also bridge impact, right? How can you combine that with impact, not just doing it faster or more accurately, right? So that leads me to the topic today, right? So what, we're talking about the role of AI in improving clinical excellence, right? So I didn't want to spend, any amount of time in actually introducing what AI is or, the definition of it. I just want to jump right in terms of what are those areas in clinical services that AI impacts today, right? Broadly, what we have been looking at, and then of course I'll touch upon a few more areas where we see the future in terms of AI, right? So one is efficiency in automation, right? I mean, not just India, but globally, you never have enough resources, right? If you talk about India, obviously all of us know the challenges, but if you talk about, place like UK, right? NHS, right? Again, not enough resources. There's a limitation in terms of the, infrastructure or the resources available, bandwidth available, patient waiting list, right? Similar with the US, right? US, the largest industry or the largest ecosystem of healthcare, still they have a challenge, right? So clearly we have an opportunity where AI can impact efficiency in automation positively, right? Second is more customer experience, the way a patient interacts with a healthcare system, right? In terms of accessing their service, right? How do they get through to the right service that they need? So that definitely has been a role where that has been a space where there's been a lot of interest in looking at, what kind of, systems that I can adopt, which can kind of smoothen that experience, right? How a patient kind of plugs into a healthcare ecosystem. Thirdly is scalability, right? Definitely, I spoke about the work that we do in terms of AI in diagnostics, right? Specifically in pathology, but be it AI in diagnostics, AI in suppose triaging, right? AI in even consultation, right? Automated consultation. So that's scalability, right? Again, you have a certain amount of resources in a healthcare ecosystem or within a provider, but the number of people who are wanting to access that services only keeps growing, right? Are you able to grow the infrastructure or your resources or your bandwidth to keep pace? Usually no, right? That's where AI can provide. So all of these examples that I mentioned, right? So AI assisted diagnosis or right at the first step, right? At triaging. In fact, I'll come to a few examples from the UK as well. So those are places where, at the basic, point of interaction of a patient into a healthcare system, if you can impact that, right? So that will solve a huge need as well. And lastly, outcomes. Outcomes is slightly more into the future because, for example, the algorithms that we do in diagnostics, right? Or even in terms of predicting a type of treatment, right? Eventually has a role in outcomes, but the evidence is still not completely there because, it's usually, prospective, right? So you're just about seeing the adoption of or introduction of algorithms into a healthcare system. Your outcomes typically don't, in some of the cases, outcomes, you are able to see the outcome within, in a short period of time, but in a disease like cancer or oncology, your outcomes are slightly more longer term, right? You're talking about survival, recurrence-free survival, disease-free survival. So that is more longer term. So that is the reason I said the evidence for the role of AI in impacting outcomes is still out there. We're still about 50-50. And a lot of the other places, we are seeing it, it's a lot more short term, right? It's pretty much tactical, right? And that's primarily the areas where, we are seeing high amount of adoption as well, right? So these are at least a few examples, right? I just wanted to put out a few examples which a lot of us will be familiar with, right? So telemedicine is primarily telemedicine is any kind of right? Connecting, patient who are in a place of low access, but connecting them to resources which are, which are where they are concentrated. But what happens is, even in the larger towns where resources are there, you already know that, the healthcare system is struggling with bandwidth, right? So when you do tele, right, you add more demand, right, to the same amount of resources, clearly there is going to be a challenge, right? That's where AI is already playing a role, right? Even in spite of, connecting hubs to a spoke, right, or connecting remote patients, you still need some assistance, right, in enabling those resources also who are at the hub to be more efficient. That is one area. EMR, especially where you have, good, in fact, we are in a state where the adoption of EMR is fairly high and adoption of quality, solutions is fairly high, right? So that has a big impact, right? Being able to look at that data and providing recommendations, right, back to the patient on type of resources that they should, adopt, from that particular, hospital or healthcare provider, that has a big role, right? AI and diagnostics, I think I've repeated that enough. I mean, there are enough algorithms already being adopted, either looking at a simple X-ray, right, especially for a trauma case, right, looking at that and actually quickly giving an opinion where, your trauma cases happen somewhere between 12 to 3 a.m. suppose, right? Clearly, an algorithm being able to quickly, detect and then give a go or no go, right? If there is a problem, that has a huge value, right? Wearables and health monitoring were the first, was kind of the first, point of entry, right? Where we suddenly saw a lot of data being collected, right? Your wearables, the biggest problem with adopting, any kind of automated or analytical or AI tools is what is the type of data it can work on, right? Wearables was, we've been seeing this for almost more than a decade, but the amount of data being collected is fairly high. And that's the reason why, any kind of automation or AI has an opportunity to do a better job, right? In monitoring, in predicting or giving any kind of alerts, right? Back to the provider, right? And last piece, I just wanted to put this because, I have a selfish interest here. So digital pathology, right? So we work in digital pathology or cancer pathology. That's kind of the current domain, which is going through a, fundamental shift in terms of going from analog glass slide based reporting to digital and even AI based reporting, right? Not just in India, but globally, in fact, right? So this is a nice resource I saw from the NHS, right? So NIHR or National Institute of Healthcare and Care Research, right, out of London, they actually did a analysis and research around the type of solutions that they've already evaluated, right? And these were at least 5 areas. So one, definitely in the area of heart disease, right? I can give an example from India. There, we know a couple of startups, one out of Bangalore, where they run a tele-ICG network, right? And they have been able to build some algorithms to ride on that. So there's a tele-ICG network, tele-ECG network. You have your cardiologist sitting available at a pool, but you can have patients anywhere. I mean, could be an ECG, could be even a recorder, right, that they might be wearing, or even a wearable, right? So, but by having an algorithm on top of that, you reduce the pressure on availability of a cardiologist as well, right? That's one. And we have seen smart stethoscopes, right? So they have shown evidence of actually predicting heart disease with a high amount of accuracy, right? Lung cancer, at least in cancer prediction, lung in particular, where we have seen algorithms which are running on, which are analyzing X-rays or even CT scans, doing a fairly good job of detecting those cancerous nodules, right? So that is one example. Progression of disease, because you always want to know. One is for example in ocular, right? What is the progression of disease? You typically have your patients coming in for follow-up. 2 is also efficacy of treatment, right? So a lot of the times the way the physician is addressing the need or the disease is to put a kind of arrest the growth of it, being able to use an AI to kind of predict whether it is progressing or is it going to lead to to an emergencies of use. This one I spoke about earlier, personalizing cancer treatment. There are a lot of unknowns, right? You still have about 40% of a hit rate in terms of treatments which work for a patient, because there are multiple variables, right? Even today, oncologists work on a statistical method, right? There's a lot of wisdom that goes into and looking at different types of patient data. There again, AI has shown a fairly good way of being able to predict what type of treatment may work, right? So we've built algorithms which can help tumor boards, right? So your tumor board is typically a collection of doctors, right? Obviously a radiologist, pathologist, but also your surgeon, radiation oncologist, your medical oncologist, sitting around looking at that data, right? And then kind of deciding on how to treat that patient. So clearly it is, just in a simple view also, there are multiple variables going into that, right? At the lowest count, it will be somewhere between 100 to 125 variables, right? If you have to kind of look at it as a math problem. There, we've had an experience of building a predictor, right? You have something called, a KM curve or a Kaplan-Meier curve, which is a survival curve for a cancer patient. At the time of, when deciding a patient's treatment, you're trying to predict, okay, what is the best treatment, right, that can be given to the patient, and in order to get the best survival, right? There clearly again, like I said, oncologists work like statisticians in this case. Obviously, it's combined with a lot of wisdom. There is an opportunity for an AI to, again, you have the oncologist plus AI to maybe have a much better accuracy in terms of, or much better prediction of what type of treatment can work, right? And definitely, right, I spoke about trauma, right? You have your cases coming in. Even before they come in, can you actually triage them, right? Can you look at what are the variables of the patient? Can you ask the right questions even while they are on their way, right? We are seeing some of it, right? So we've interacted with a couple of the ambulance companies, right? So, can you ask the right questions, and even before they are wheeled into the hospital, can we actually triage correctly and then get the right solution lined up, right? So there's a lot of the times you want to, get the resources ready at the hospital even before the patient comes in. AI can help in readying that as well. Yeah. Ultimately, so all of this is, we talk about clinical excellence, right? Ultimately, the goal, that we are trying to, achieve is, at least on three, right? I try to simplify it, right? One clearly is access, right? So you have patients, you have certain amount of services, you have certain amount of expertise, right? Connecting them, right? And enabling them to get the best out of those resources, right? Improving access, that is definitely one. Second is compliance, right? So you have certain amount of guidelines, right? A lot of the times, it becomes an iterative cycle in terms of the treatment given to a patient. Definitely if you have an AI-based, workflow mechanism, there is an opportunity to increase compliance as well, right? The type of treatment given to the patient, get to the bottom of it, fairly early, rather than you already have some loss of time, right? And lastly, of course, outcomes, right? So outcomes, I mentioned patient satisfaction, because ultimately satisfaction is determined by the kind of outcome that the patient has. But like I said, that's ultimately our determinant in terms of what worked and what didn't work, right? And that these three become the barometer, right? In terms of barometer of, we can say, success, or barometer of how well something was designed, right? How well it was adopted, right? So that these three would kind of give you a sense of how good the solution was, right? And then ultimately it's still a journey, right? From towards clinical excellence, it is a journey. AI is just one of those you can say tools, right, which can help you kind of travel towards the clinical excellence, right? So there is still there are quite a few other things, right? It's not as easy as just putting or switching on AI, right, in a healthcare entity, and then expect that in a day or in 3 months time or in 6 months time you will actually you can call yourself a excellent healthcare setup, right? There's a lot more to it, right? So because in our experience, the biggest determinants of a healthcare setup, there are enough examples on both the sides, right? There's a huge graveyard of solutions which have got adopted, and then eventually either in 3-6 months or even 4 to 5 years, the hospitals have just switched it off, right? Because they really did not show that those kinds of outcome, right? So what are those? So these are some learnings that at least we've had, where if you really want to switching or adopting a new AI into any kind of process inside the healthcare entity, there are a lot more things that you would do well to kind of ensure, right, even before you actually adopt, right? So I basically call it vertex, because these are factors that basically make a go or no go decision, right, for a clinician or for a hospital, right? Because any of these that you see on this page are each of those are going to as critical as a go or no go, right? A lot of these we kind of these are 6 different factors, but each of these have an important enough role. A lot of the times, at least from the learnings that we have in the industry, right, it's either one of these where maybe a provider or even a technology provider thought let's skip this, but at least it's showing something, it's showing some results, let's go ahead with it, right? It definitely is. You can't. The lesson is, we shouldn't be doing that, right? First is validation, right? I know even before validation comes evidence in terms of what type of AI do you want to evaluate for your, for a clinical entity, right? Or what should be introduced, right? The evidence comes from having done enough of clinical validation, clinical trials, running, and showing a huge, a proper workflow in terms of the way such a technology was built, right? That is evidence, right? That in fact that would come even before validation. Then comes actually validation. So validation in this case, I'm not talking about a proper clinical validation and trial. That's a given, but even a small batch validation in terms of adoption, right? So there are quite a few AI solutions. Not all of them is going to work for a healthcare entity, right? Doing that small batch validation, what we call a calibration study, introducing it into your workflow, into the hospital, and actually checking, hey, does it work in my setting, right? Does it work for my hospitals? Does it work for my doctors, right? Does it work in my workflow, right? So every clinical entity is different. Every healthcare provider is different, right? And doing that small batch validation in that particular entity where it is going to be introduced is as important, right? The AI could have been developed, with collaboration with the best clinical institute, cancer institutes or healthcare institutes across the globe, across India. But that validation in your setup, right, is paramount, right? I can't underplay it, in any way, right? Then comes evidence that I spoke about already. That evidence is like the basic gate, right? Unless unless it crosses that gate, you don't want to be even looking at it. Regulatory, right? The way a technology can be introduced into a healthcare provider is always a big part is by the regulator, right? So at least from an AI standpoint, while maybe about compared to 3-4 years back, there's a lot more maturity now among our regulators, right? So at least in India, the regulator is someone called CDSCO. I'm sure you might already have exposure to that, but there's a lot more maturity among our regulators even in India in terms of how do we regulate this, right? How do we help healthcare providers or healthcare entities to evaluate something, and what are those stage gates that an AI technology has to cross, right? We are still there. We are not completely there in terms of, exactly determining, regulatory compliance, but we are definitely about, 10 times better than what we were about, 4-5 years back, right? So that definitely, right, especially for a healthcare entity, regulatory is a big part of, how we operate, right? Make sure, it has all those right checks and compliances, right? Second, I, call about transparency, right? What kind of information went into, building that tool, building that software, right? Building that AI, right? Because ultimately AI, what is AI, right? It's basically where we are teaching, a system or a computer in this to behave like a human, right? And actually do the job, right? Do the job well. But to do that, in terms of the training, there's a lot of data that goes into training of it, right? For example, we work with about 6 clinical partners, right? Now we are commercial, right? We've been commercial for the last 2 years. The 4 years before that, right? We were purely only in research collaboration. So we had 6 partners in India, we had 2 in the US, 1 in UK, right? So even today, so if you want to adopt something, you should be able to ask the technology provider, right, to be transparent about what went into the development of that AI, right? What kind of data, what was the spread of the data, right? What type of, what all, different variants of that data went in. Was there, if you have, in this case, was there proper IRB approval, right? Did they follow the right channels, ethics approvals, even before the data went into the algorithm, right? A lot of these sound kind of simple. I mean, as long as if we have, 1 or 2 ethics, right? I'm okay. It comes back to bite us, right? Not now, it could be 3 months down the line, could be 5 years down the line, but it has a huge cost, right? Especially as, a lot of these healthcare institutions are built on not just quality, but also reputation, right? So that definitely, it's like I said, that's why it features on this page, which is a go, no-go page, right? Next is, of course, clinician involvement, right? So no AI which didn't involve doctors from day one, right? In fact, if they did not even have, even if as high as, involving doctor in the actual development of it, right? None of them have worked, right? There have been huge classical examples, even from, places like in the Western world, right? UK or US, which were operational for about 7-8 years, right? Raised a lot of funding, got, introduced in a network like even NHS, they just went bust because somewhere, clinician, when they went back, right, the amount of involvement of doctors, of physicians in the actual development of it, because doctors don't just give, don't just evaluate AI, right? So there's multiple roles a doctor can play, right? Evaluating the AI, whether it is correct or not, right? Does the AI match what I'm going to say? But also in our case, right, doctors also have a huge role in determining adoption, right? Am I going to find it useful? This looks cool, but when I'm sitting in my OP and seeing the patient, I have about 7 to 8 minutes, right? Is it really going to help me? Am I going to adopt it, right? That's a very, very interesting and critical question where a lot of the solutions fail, right? OP is of course just one example I'm giving about, right? But was the clinician involved in the actual development of the AI, right? And lastly, scalability, right? Again, the best AI don't succeed because they just can't scale, right? In our country, you definitely need solutions which can scale because, for example, I'll give an example from our experience. So telepathology, right? So we ran a AI telepathology network. We still run it, right? In a state government, connecting CHCs and PHCs to a district hospital, right? To start with, it was very interesting, right? Suddenly, pathologists who were walking into this CHC where the gynec wanted the patient to get a test done, right? Wouldn't get it done because there was no access to resources locally. They were able to do it because we were enabling what is called telemicroscopy, right? Live view of the pathology from 110 kilometers away, right? And everything was great, but in a few months' time, what we realized, the pathologist who was doing the reporting, she doesn't have extra capacity, right? She was already working at full capacity, working in a government hospital, and now we were saying, what? In addition to the cases from the district hospital, also look at these cases from the CHC and PHC, which is equal to 100% of the cases, right, happening at the district hospital. So suddenly, there, it has to be scalable, right? Just because it, generates that demand or suddenly has, access, improves access, and there's a lot more demand. So we had to be a lot more creative, right? The main time that the pathologist was spending was on entry of the data, not on reporting, but entry of the data, right? So by simply, we had some, solutions to either do a voice recognition and enable them to, enter that data, or just a simple DE, right? A data entry operator, right? DEO, just sitting at that place and doing that. So small solutions which kind of address where that adoption goes wrong, right? So that is primarily what we call vertex, right? So primarily each of these are critical enough, and definitely clinical setup cannot ignore any of these, right? Any of those definitely it's going to come back to bite the clinical healthcare provider, right? And lastly, after you've crossed all of that, right, something equally important is change management, right? Because here you are introducing some solutions that are foreign, right? Just like when you put an implant, right, it's a foreign body, right? The body takes some time to get used to it, right? You go through so much compliance even before you go for that implant, right? Here you're again, you're saying, hey, I'm going to introduce this foreign body called AI, right, inside a healthcare setup, and I expect it to, absolutely run, right? So there's a lot more that you would need to do, right, in terms of tests, right, to ensure even after the introduction of the AI into that, healthcare entity, it's still going to work. The body is not going to reject it, right? The hospital or the healthcare entity is not going to reject it for a variety of reasons, right? Now you'll have, obviously we are all humans, right? Anything, even a new phone, there's so much, so much of learning that we have to go through, right? There is resistance to change, right? And there are different types of staff inside a hospital, right? So that definitely, suddenly you're saying, don't look at, so radiology went through this, obviously, right? 10 years back, right? Suddenly you're saying, hey, don't look at film, right? I'll give you a monitor, right? It's as good as film. There's nothing, right? People would say, no, my eyes, I can't look at monitors for too long, or film, how can I do that? Well, films capture all the information, monitors, there's never a high resolution, multiple things, right? So there are different ways to look at this. So that definitely is a point, right? Training and skill development for sure, right? This is a new way of, of course, as much as you try to make AI seamless, right? And kind of cut down the difference between, with AI workflow and without AI workflow, there's still some amount of training. It's still introducing a certain additional step, right? That also, directly binds into AI integration into workflows. There cannot be a new step. The best way to make sure an AI will fail is to, kind of disrupt the workflow, saying that, hey, I want you to do this additional step, right? Just because you have AI, that's the best way to, make sure it fails. Because any new step does have a challenge, right? So you're already pressed for time, pressed for resources, right? You don't want to have something which comes into the workflow and introduces a delay in terms of time or resources, right? And lastly, last step is, measure, monitor, iterate. So it's a cyclical process, right? Just like adopting a new technology, right? Nothing is, is going to work, like I said, right? Even in a day or 3 or 6 months or even, longer than that. It's always about, there are certain goals that you have, right? Definitely monitor, are they measuring that, right? And then there are always improvements. The good thing about algorithms is, there's always constant retraining, right? We released our first, for example, breast cancer panel, right? Which does AI-based scoring on IHCs. We released it 12 months back. And the same product that we have today, the breast panel AI that we have today, is much better than what we had 12 months back, right? So there's an iteration that constantly goes, right? So we went through the regulator, got the product approved. Now we have the third version again, which has gone through the regulator, got approved, right? That is the algorithm which is available, because, as AI looks at more data, more patient data, more images, right? More variations, it only keeps getting better, right? Like I said, AI, the first versions of AI have been to mimic what the doctors do and mimic it well, right? Just like the wisdom of doctors, right? A doctor with 40-year experience obviously has, they have more wisdom, right? Because they've seen more cases. So is the case with an AI, right? And that's why we say, doctor plus AI is the future, right? It's for us to kind of adapt and then be ready for, what the future holds for us. But, just those things that we need to take care, make sure, something well planned, right? It's going to be a lot more successful. Yeah. Thank you. I hope that was useful. I know I take maybe about 30 minutes time. If there are any questions, we'll be happy to take them. Yeah. Yes. Treatment planning. Oh, great. Fantastic. Sure. Sorry, wearables and digital therapeutics. Is that a question?
Yeah.
No. So wearables is as simple as, a watch,
smartphones,
patch, right? So it's basically, you have continuous monitoring. So I'll come to the first question as well.
Yeah.
But basically continuous monitoring, right? The good part is you have continuous monitoring, you have longitudinal data. Digital therapeutics is slightly longer, where you can actually have an algorithm treat the patient. Or provide an intervention, right? As simple as change in their diet, as simple as that. You have ingestibles, right? So what we call, therapeutics or theranostics, right? So there are where it actually impacts. It gives a some kind of recommendation back to the patient or the clinician or via the physician, and they actually follow that. Wearables is usually hardware, right? I have it, and it's close proximity, right, with the patient and collecting data. Digital therapeutics, in fact, need not be even a wearable. It could be purely as simple as a questionnaire also, we've seen, right? In some cases in neuro, it's as simple as a questionnaire, and then they give a recommendation back, which the patient acts on. That's a therapeutic. To the first part, I think you mentioned treatment prediction.
Treatment planning in radiation oncology, because
Sure.
fundamentally you're talking about oncology.
Yeah.
And we see a lot of fantastic work being done in the area of pathology.
Right.
So that is fundamentally helping with the clear-cut early diagnosis.
Correct.
Clear precision in terms of diagnostics. I think a lot of work is also done in the area of treatment planning in terms
Sure.
when it comes to artificial intelligence associated planning in
Yeah.
radiation oncology. Any work on that front?
Per se, we haven't done, right? I've seen courtesy because we work with a few oncology programs. So radiation oncology. So we have, I don't know if I can call it AI, but we have seen, oncology networks they have this, network of these liniacs, right? And, you can call it telephysics, right? You can centralize that, right? One, there is a line of, school of thought where, based on the outcomes, I can come back and build, some kind of recommendation tool even for my physics, right? Even for my planning, right? For even before, so I have, basically type of organ or type of treatment, right? What was the protocol, treatment given, right? You have post treatment. If you have data, outcome based, you have a algorithm which can actually say, okay, next time I plan for it, these are the inputs that go back in, right? So that's what telephysics doesn't have any AI. Purely, there's no AI. It's just you're only centralizing your resources, but there is an opportunity for some kind of automation, right? In terms of doing it better, right? Because of course you have your integrated CT data, all of that going into, planning out your map. The same, doing it better, right? So because it's a function of your linears are getting more and more sophisticated, right? You're trying to figure out how to, reduce the number of fractions. That's where this is also going, right?
My third question again on cancer.
Sure.
You mentioned on identifying the right kind of mode of treatment using AI.
Yeah.
Does that mean that you're integrating with theranostics?
No.
Because as we speak to oncologists,
yeah,
the more and more you speak to nuclear medicine consultant, they say the way forward is theranostics, because that would tell you the marker.
Sure.
Wherein actually based upon outcomes, what kind of molecules to be used.
Sure. So I wouldn't call it theranostics per se. I mean, so you have a lot of...
Yeah, probably not theranostics.
Sure.
Yeah, sorry.
But you have a lot of these, I don't want to call it that, but experimental therapies, right, which have been going on for almost, 12, 15 years, even in India. But I'm not very sure. I don't know if it's, you can predict that because it's still experimental, right? But in treatment prediction, there is, you can actually, so based on, because I've done this, maybe I'm kind of slightly biased to it. So there is an opportunity to look at data, right? Multiple types of data, lifestyle, ECOGs, right? Diagnostics, which is pathology, radiology. If you have sequencing data, great, right? There is an opportunity to, with a fair amount of accuracy, actually draw that KM curve by patient.
Exactly.
And give a risk scoring. What's the protocol to be followed, right? What do you want to lead with? Of course, the input is basically history, right? So we had this specific example, we worked on a place where we looked at close to about 9,000-10,000 data of breast cancer patients, and we had decent quality data, and we basically gave a risk scoring, right, in terms of what type of treatment, right, or what should be the protocol for each of those patients. But again, like I said, so my first point, it is still retrospective, right? So treatment prediction, you would always want to we never did a prospective. We basically built a predictor for a cancer network who were doing a tumor board. They're working on. So of course, such things work where you have a tumor board way of functioning. There it was no.
My last question is a pretty hilarious one.
Okay.
You see on WhatsApp about China. In China, you have an entire OPD be run by AI. How far it is true to your knowledge?
I don't.
They say that 2,400 OPD is done by artificial intelligence.
So
in cabins, how far it is true? Even I'm curious to know.
I don't know if it's true or not, but I wouldn't want to go to that OPD. That's all I can say.
Thank you.
Sure. Great.
Any more questions?
Great. Thank you so much. Right. Thanks for being an engaging audience as well. Thanks.
Thank you, Mr. Dinesh, for